My name is Zixin Shah, and I am a second-year medical student at the University of Florida College of Medicine. Here I am presenting a rare case of an atypical extrabronchial hematoma following robotic-assisted bronchoscopy with an unusual distribution along the thoracic esophagus. Robotic-assisted bronchoscopy has significantly improved the diagnostic yield for peripheral pulmonary nodules. While iatrogenic hemorrhage is a known risk, it typically manifests as intra-procedural luminal bleeding. Extrabronchial complications with delayed presentation, as seen in this case, remain poorly characterized. Our patient is an 80-year-old male with a history of chronic obstructive pulmonary disease, metastatic prostate cancer, status post-radiation and chemotherapy with local recurrence, and lower extremity deep vein thrombosis, who has been on 1 month of apixaban. He presented to the emergency department with acute respiratory failure. Computed tomography of the chest found a new suspicious left hilar spiculated nodule. Following a standard 2-day anticoagulation hold, he underwent an endoscopically unremarkable robotic-assisted bronchoscopy with transbronchial lung biopsy and endobronchial ultrasound-guided transbronchial needle aspiration. He was discharged with home oxygen without immediate complications. Pathology later confirmed primary lung adenocarcinoma. However, 4 days later, the patient returned with acute hemoptysis and persistent shortness of breath. Upon readmission, the patient was hemodynamically stable but demonstrated significant physiological stress. As shown in Table 1, labs were notable for elevated troponins at 124 and 134 nanograms per liter, elevated B-type natriuretic peptide at 428 picograms per milliliter, and hypercalcemia at 13.6 milligrams per deciliter. This time, chest CT revealed a new complex subcarinal and posterior mediastinal fluid collection measured up to 5.1 centimeters, attributed to blood product from bronchoscopy. This hematoma demonstrated an atypical anatomical distribution tracking along the mid to distal thoracic esophagus. Notably, despite its size, there was no significant tracheal or esophageal compression. The patient was admitted to internal medicine with pulmonology consult. He was managed conservatively with nebulized tranexamic acid and an additional 3-day hold of apixaban until hemoptysis resolved. While follow-up imaging proved that the hematoma remained unchanged in size, on hospitalization day 5, he developed dysarthria and facial asymmetry secondary to a subacute embolic stroke and a concurrent segmental pulmonary embolism. Given the cumulative multi-system decline, after conversations regarding goals of care, the patient elected for hospice care at home and passed 9 days after discharge. We present this case of rare iatrogenic bleeding following robotic-assisted bronchoscopy, highlighting its extrabronchial location, delayed presentation, and interesting anatomical distribution. In addition, this patient carried multiple risk factors for iatrogenic bleeding, including hypertension, malignancy, and anticoagulation. This case also brings to attention the challenge of managing peri-procedural anticoagulation in high-risk patients with malignancies. Lastly, we emphasize the necessity of early goals of care discussions in patients with advanced multisystem disease to ensure timely transitions to palliative care. Thank you for your time.